Good afternoon, and welcome to Trauma and the Experience of Facial Pain, featuring Dr. Lisa Scott-Morrow. I'm Melissa Bombick, CEO of the Facial Pain Association. Welcome, Dr. Scott-Morrow. We're honored to have you with us today.
Thank
Just a
you.
few housekeeping items before we get started. If you have questions, please add them in the Q&A feature on the right side of your screen. We'll try to monitor both of the Q&A and the chat, but it would be easier if we leave the chat for attendee connections and conversations. Following Dr. Scott-Morrow's presentation, we'll get to as many questions as we can. Please understand that none of our presenters today can answer specific questions about your situation. However, we will be asking general questions applicable to the most people living with facial pain. I'd like to introduce our speaker. Dr. Scott-Morrow completed a PhD in clinical psychology in 1990 at the University of North Texas. She also completed a degree in law at Indiana University School of Law in 2002 and is a practicing, fully licensed clinical psychologist. Her practice involves a blend of clinical work, teaching, and writing. Dr. Scott-Morrow served as attending faculty in the Family Practice Residency at the University of Texas Medical Branch and in the psychiatry residency at the Indiana University School of Medicine, Department of Psychiatry. Dr. Scott-Morrow served as faculty at the University of Minnesota School of Dentistry in the Division of TMD and Orofacial Pain, and also within the Department of Neurosurgery Facial Pain Clinic at the University of Minnesota School of Medicine. Dr. Scott-Morrow, please go ahead.
Okay, great. So we're going to be talking about the ways in which the experience of facial pain is traumatizing. And to get us going, I'm going to review the trauma diagnoses under the DSM-5 TR. We're hoping not to get too mired in the details, but let's start with some foundational information. So probably most of you know that the DSM-5 is the diagnostic book that we use in mental health and psychiatry and psychology. And there's a chapter in that book devoted just to trauma diagnoses. And the ones that are most commonly used are acute stress disorder. And this is a diagnosis that's appropriate right after exposure to a traumatic stressor. And we'll talk more about what that means in just a minute. Right now, it may all seem a little bit like, what does this have to do with facial pain? But just hold on. And then post-traumatic stress disorder, which everybody knows about, but really the mechanics of PTSD, most people don't understand. So we'll talk about that. And then sometimes people have trauma-related symptoms that don't really meet the diagnostic threshold for any of these things. So we call those disorders other specified or unspecified trauma and stressor-related disorders, meaning that there's some trauma symptoms, but they don't reach the threshold for PTSD typically. And then there's an adjustment disorder. It's a trauma-related diagnosis as well. And when we make a diagnosis of adjustment disorder, we typically say with depression, with anxiety, or with both. So it's kind of a blended diagnosis that includes depression or anxiety, or most commonly, I think, both. But because everybody is interested in PTSD, I think, let's talk about it specifically. And as we go along with this discussion, I'd like to encourage you to think about a couple of things. One, you may have some of these symptoms and not all of them. So you may not reach the threshold for a diagnosis of PTSD, but you may have some of these symptoms. And if you do, that's significant. That's meaningful. The other thing I'd like to say is some of you, statistically quite a number of you, have probably had traumatic exposures before you had facial pain. Growing up or something along the way has happened. The research teaches us that approximately 50% of people, that's a lot of people, have had PTSD level trauma exposure. So I'm guessing that half of you had some sort of trauma exposure before you experienced facial pain. So when we make a diagnosis of PTSD, there are several criteria, and we have to have diagnosis on all of those criteria in order to make a diagnosis of PTSD. The first criterion is the stressor. That's the thing that you experienced that caused this trauma. And it has to be of a certain type. We'll talk about that next. The criterion B involves reliving symptoms. C, trauma, you can see the slide. Trauma-related avoidance. Criterion D, changes in mood and thinking. And criterion E, hyperarousal symptoms. This doesn't mean anything to you right now, but it will in just a few minutes. So let's talk about the stressor. And this is very, very specific, okay? It requires exposure to actual or threatened death, actual serious injury, or actual sexual violence. And you might think, and I think you would be right to think, well, facial pain doesn't really fit neatly in there anywhere. I mean, it doesn't threaten death. It's not an injury, or for some of you it is, but for most of you, it's not an injury, and it doesn't involve sexual violence. So how do we connect facial pain with PTSD? Well, let's look at the next thing. It involves criterion A stressor exposures involve intensely stressful watershed events in the life of the person. Now we're getting closer to facial pain, especially when you're having the kind of facial pain where you have attacks or episodic periods of struggling with facial pain. And the first time that happens, and you know this well from your own experience, it was intensely stressful. For most all of you, there was a period of time before facial pain and a period of time after facial pain. And so the experience of facial pain is a watershed event. There is a before and after experience. So in that sense, we're moving closer to the criterion A stressor. So let's look at some of the examples. Exposure to war, physical assault, either actual or threatened, sexual violence, actual or threatened, being kidnapped, being taken hostage, terrorist attack, torture, incarceration as a prisoner of war, human or natural disasters, severe motor vehicle accidents. And again, the connection to facial pain is not obvious at this point, but let's keep in mind how intense those stressors are, and we'll begin to see facial pain come into the picture. So what about serious medical illness? What about chronic pain? Certainly these experiences are traumatizing. So surely this signature diagnosis of trauma, surely there's a place in there somewhere for what you're going through. And I think there is, although it's not typically thought about. It's not on the radar of most trauma treating professionals, but most of them, frankly, don't know what facial pain is. They have no idea what trigeminal neuralgia is. So in the DSM-5, in order for a medical event to reach that criterion A stressor threshold, it has to be a particular event, something that starts and ends, that evokes catastrophic feelings of terror, pain, helplessness, or imminent death. And the examples that are given in the DSM are waking up during surgery, or the agonizingly painful experience of having severe burn wounds debrided, or the experience of cardioversion, being shocked to correct your heart rate or your heart rhythm. Those things all have this in common. They're scary, they're startling, they occur in a moment, they're unusually intense. And if you think about that, if you think about it in that way, the experience of facial pain, especially that zapping, electrical, lancinating pain, has those qualities. So even though no one thinks of trigeminal neuralgia or facial pain as a PTSD causing experience. I would argue that it is. And the repeated nature of the attacks is clinically significant too. About 50% of my practice is devoted to treating and diagnosing and treating trauma. And I have evaluated a lot of police officers and ambulance personnel, and they have repeated exposure to stressors, and it causes an increased risk for trauma-related pathology. And if you think about facial pain, the same thing happens. You have repeated episodes, and you may have successful treatment, but it doesn't stick forever. And the facial pain attacks come back. And so in that sense, there's a kind of an overlap. If you take the broad picture view, there's a kind of an overlap with people who are exposed to repeated trauma as a result of their work. I mean, it's the repeated nature of it that you share with those folks. So, technically, facial pain does not qualify based on the letter of the DSM-5-TR, so the letter of the law kind of things. In most cases, facial pain is a chronic illness, and PTSD is designed to address episodic experience of stress or exposure to a thing that happens and a thing that ends. But as I've said, and as you know, facial pain can involve sudden, intense stress that is more like a heart attack in its acuteness than it is like diabetes in its chronicness, if that makes sense. Facial pain can involve attacks or events, and they are very, very significant when they occur. And so I would argue that there's a place for facial pain in the PTSD diagnostic system. So let's look at each of these criterion. And here's where you should perk up and begin to see yourself. Some of you will see yourself. Some of you will see difficulties that you've been having that you have not associated with the traumatic aspects of your facial pain. But in fact, the difficulties that you're having are related to it. So the criterion B thing is about reliving the trauma, thinking about it, being haunted by it. And that can occur in a number of ways. It can occur through recurrent distressing memories. And these things are, the nature of these memories, they're not like regular memories at all. They're substantially different from regular memories. They are even coded or stored in a different place in the brain. They're very different. So these memories tend to be involuntary, intrusive, and sensory focused. So the memory isn't thinking about the broad experience of facial pain. It's remembering the actual facial pain. And it involves that sensory recall. And I'm sure this is happening to some of you. Being haunted by these memories, having this experience pollute your everyday life, apart from the actual experience of pain, but recalling it with such vividness that it's almost like it's happening again. Recurrent distressing dreams. These are the nightmares that people think of when they think of PTSD. And some of you may be having dreams about your experience of facial pain. Prolonged psychological distress and exposure to cues that symbolize or resemble a part of the traumatic event. These are the triggered distressing memories. So for facial pain, this can take on a kind of unique character. So you may be outside and it may be windy And you may not be having any facial pain, but being exposed to that wind, which has in the past triggered your facial pain, conjures up a kind of anxiety and agitation that is more intense than your typical experience of anxiety. It can involve physical arousal, fast heart rate, tension in the body, muscle tension. I mean, it can be a very intense experience, and it's triggered by exposure to things that were at one time in the past actually connected to the experience of facial pain. And for some of you, these triggers may have to do with the treatment of facial pain, going into the hospital, and it may make it difficult to go to the hospital to visit a friend. These can take so many different forms. It's really impossible to identify them all, but you can do that for yourselves. And the overarching thing that you should be paying attention to is anything in your environment that can bring back to your mind the experience of facial pain in a way that is so intense that it takes you out of your experience. It is all-consuming, the anxiety and agitation. So that's criterion B. Criterion C. Criterion C is the avoidance criterion, which is why I have the deer in the headlights. This is doing anything in your power to stop the experience of facial pain and to stop the thoughts of it. So as this goes on, you develop a two-layered experience. On one layer, there is the actual experience of facial pain. But then on this other layer, there is the memory of the experience of facial pain. And these things begin to stack. And people do all kinds of things to try and shut off the experience, to shut off the thoughts of it. So my greatest worry for patients on this criterion is using substances to shut that off. People who've been traumatized are at very much increased risk for using drugs, including alcohol, to shut it off, to shut off the distress, to shut off the thoughts. And obviously that can lead to a problem. And it is also very common for people to have an increased use of these substances for the purpose of shutting off this distress without recognizing that it's connected. And that creates serious problems. And for people who have chronic pain, the experience gets much more complex and tortured, really, with the use of opioids, because opioids create a kind of dissociative experience. And by that, I mean it splits off your thinking. They split off your thinking. They shut down the thinking part of the mind. And people can begin to use opioids not only to relieve the source of their pain, their facial pain in this instance, but also because it shuts off the psychological distress that goes with the whole experience. Only that part they don't usually recognize. And then it creates this very tangled up experience where distress, psychological distress, gets wrapped up with the experience of pain, and the person can't any longer identify where one starts and ends and the other begins. They get so tangled up together, and that can lead to a perception on the part of the individual that they need more opioid or more benzodiazepine or more alcohol to address their pain, when partly what they're addressing is their psychological distress, which may not even be something that they recognize as associated with facial pain between episodes. Criterion D. Okay, criterion D involves disturbances in mood and thinking, and many of these symptoms are like symptoms of depression. So there's a great deal of overlap, but it's important for those of us who are clinicians treating these trauma-related disorders to identify whether the symptom is depressive in origin or whether it's trauma-related in origin, because the treatment's different. And you want to be sure to target the treatment to the actual cause or etiology of the symptom. So let's look at these together. Becoming cynical about human nature, or, and here's where it's more likely to be an issue for you all, viewing yourself as permanently damaged or ruined. And I mean, this feels rational to some extent. It's like, well, I have this thing and it's bad and it keeps me from being able to do stuff that I want to do. And it keeps me sometimes from being able to do stuff with my family or my friends. And yes, I do feel damaged in a permanent way. But it's important to recognize that that thought process is trauma related. It's trauma related. It is not an inevitable part of the experience of facial pain. And it's important for us to recognize that, because we can treat that. We can treat that. And then you don't end up feeling that way persistently. And it's really miserable to feel that way. The other thing that can happen is people can begin to irrationally blame themselves or others for their, I know this makes no sense, but I feel like I did something to cause this. I'm being punished. This disease, this thing is a punishment of some kind. That's how it feels. And sometimes that thought process can catch on fire to such an extent that people begin to actually lose awareness of the fact that it is irrational. And it starts to feel real, that really they are being punished. Or really that other person in your life is causing this somehow by creating a kind of stressful experience. But it's important to recognize that that's a common thing in people who have been traumatized, that irrational self-blame or irrationally blaming others. And I mean, obviously, that irrational blaming others part can be directed toward physicians who, you know, I'm not here to defend every physician, because sometimes they mess up just like all people, but you know, you can develop this symptom can cause you to view an unsuccessful surgery or an unsuccessful treatment as something that the physician did. The physician messed up. And it's part of that tendency to irrationally attribute blame that we see with trauma. Persistent trauma-related negative affects. So going through this experience can cause people to feel negative feelings most of the time. They become a predominant part of their experience. And it can involve any of these feelings that I have listed here: fear, guilt, horror, anger, shame, any of them, all of them. The experience of trauma can cause this sort of black cloud of negativity to settle in on people. And, you know, the same thing can happen with depression. But with trauma, these negative feelings can involve more fear and horror than with depression. People can also lose interest in activities, the things that they used to enjoy, even if those things are not triggers for facial pain, but just things that you once enjoyed, you don't enjoy anymore. You don't have the drive to do them. Maybe you used to, I don't know, go fishing. Maybe you used to love fishing. but you don't feel like fishing anymore. Or maybe you used to paint pictures, but you don't feel like painting pictures anymore. That loss of interest in activities that were once important to you is typical of trauma. And if that's happening to you, you should, at this point, be asking yourself, oh my God, could this be related to this traumatic experience of facial pain I'm having? And the answer is yes, it can be related. And this same process can cause people to disconnect from others. And this is really tricky here. It can cause your feelings for other people to go numb. And so people that you're attached to, that intellectually you love your wife, you love your husband, you love your significant other, you love your children, but you don't feel it anymore. And oh man, first of all, people rarely recognize that that's a trauma response. They feel it happening, but they don't recognize that it's connected to trauma. And they blame themselves and they feel guilty. And then typically their spouses can sense it and they begin to wonder what's going on. You don't love me anymore. Are you having an affair with someone? I mean, really seriously, this can get very destructive. And it's important to learn, to understand, to recognize that this can be a trauma response. It's nothing you've done wrong. It's nothing that your significant other's done wrong. No one has done anything wrong. It's just a natural response to trauma. We can treat it. It's a pathology, but it comes with trauma. And then along with that, the inability to feel joy, the inability to enjoy things goes, the capacity to become immersed, absorbed, and enjoy something goes away. And it could be something as simple as the capacity to hook into a movie and watch it from beginning to end and be engrossed, or go to a musical or a play, or to take pleasure playing with your grandchildren. It can take all manner of forms, but the significant connection between all those things is just a fundamental incapacity to feel joy. And that too is a trauma-related reaction. It's important to see that that's possible, that those things can be connected. Criterion E, okay? There's a reason why I included the shuttle. It's because criterion E involves hyperarousal symptoms. It's the nervous system being ratcheted up. And this comes with trauma. Let's look at the symptoms. Irritability, aggressive behavior, not characteristic for you, not something that is what you typically do. But here it is. It's starting to happen with no provocation. So people start walking on eggshells around you. You're doing this. You know that you're snapping people's heads off. You don't know why. And you can't stop. You feel guilty about it. And you see how these different criteria start to kind of get tangled up together. So now the irritability and aggressive, anger and all that starts to make you feel guilty because you're hurting people that you love. And then that guilt trails back to criterion D, where you have this persistent negative experience of guilt. So these things kind of bleed together. And I'm here to say, if you're struggling with increased irritability, it could be trauma related. The other thing we see sometimes increased self-destructive or reckless behavior, taking risks that you wouldn't normally take. And, this tends to happen more in younger people. Oh man, I have seen combat veterans that get in their cars and drive 80 miles an hour down the highway, cutting in between cars and tempting death. That is a trauma thing. That's a trauma thing. Increased use of alcohol in a way that is risky can be a trauma thing. Hypervigilance, radar out the wazoo, looking for any possible trigger for facial pain. In every environment, looking for something that could cause it. And obviously this backs up into criterion C with the avoidance stuff. So they go hand in hand. But this hypervigilance is physiologically amped up too. It's not just watching for trouble, but it's experiencing the agitation and fear that goes with the feeling of trauma being around the corner. And also a part of this hyperarousal experience can be an exaggerated startle response. It's interesting, being jumpy. It's interesting. I can be interviewing a patient and I'm trying to figure out, what am I looking at here? Is this a trauma thing that I'm seeing here? And then a door will slam and poof, they jump up off their chair, That is typical of someone who's got a trauma-related pathology. Or maybe they don't do that. Maybe they just sit peacefully and didn't even seem to hear the door slam in the nearby environment. To me, that tells me that they may not have PTSD. And I suppose I should say that, I said earlier that 50% of people are exposed to some sort of traumatic stressor that qualifies under DSM-5. But here's the thing, of those 50% of people, only 7 to 8% will go on to develop PTSD. So it's actually a minority of people that develop the full diagnostic picture. But then there are a whole lot of people that have isolated trauma-related symptoms. And I'm thinking that's probably true for a number of you. You may not have all of these. You may not have symptoms on all of these criteria, but you have some. And I think it's worth talking about because my experience as a clinician is that people often don't associate these emotional symptoms with trauma exposure because the trauma is not happening in that moment. I mean, these symptoms are happening in between the traumatic experiences and people are not connecting. They're not connecting the dots. And I think it's important for people to begin doing that, connecting, to begin seeing it. And then the other biggie is insomnia, just not being able to sleep, trouble falling asleep, trouble staying asleep. And I'm telling you, that needs to be treated. That must be treated because if you're not sleeping well, your body will suffer. You will have more facial pain. You will have a harder go of it. So those are not symptoms in my mind. These are not symptoms that we can ignore. All of these symptoms indicate something serious going on that needs attention. This is not something, with kindness in my heart, this is not something you can do yourself. You need help if these are things you're having trouble with, all of these things. So what? What do we do? What kind of help? Psychotherapy. It won't surprise you to hear I'm a big fan. But, there are some things that people can do on their own. They can. There's some emotional experiences that people can handle on their own. They can read a book. They can do some relaxation stuff, some stuff on their own, and they can feel better. But these trauma-related symptoms, no, you can't. You can't. And the reason why is because trauma is burned in the brain. I mean, I really didn't talk about that much. I don't have any slides devoted to it, but it's important to mention that if you have trauma-related pathology, it involves brain-related changes. It involves physiological changes in the way the brain processes information from the environment and the way the brain codes memories associated with these traumatic experiences. And consequently, and why this is so important, is because the treatment must address those physiological changes. You can't get better if you just come in and talk about how awful this is, or come in and talk about it, and the therapist understands and provides support. That will make you feel better for a while, for an hour or two, or maybe a day or three, but it won't fix the problem. The treatment for trauma-related symptoms has to be of a certain kind. It must involve some relaxation component because the body has been traumatized, and there is this increased arousal that's associated with the trauma response. So we've got to cool that off. We've got to settle that down. And we can do that with biofeedback. We can do that with acupuncture. I just read a whole series of new studies coming out that show that acupuncture is a successful treatment for trauma. Who knew? Maybe you did, but it was kind of surprising for me. Yoga, deep breathing, all of these things, combinations of these things, but something in this group needs to occur. Now, my feeling and the research would say that's just a part of what needs to happen, but it's not enough. Eye movement desensitization and reprocessing, EMDR. Some of you have probably heard of it. Maybe some of you have even gone through EMDR. And it's outside of the scope of this presentation to go over how we do EMDR, but just let me say it's a thing. It has a special technique associated with it. Its technique involves something more than talking, and it retrains the traumatized brain. It helps to fix that injury. And I mean, the injury of trauma occurs at the level of the brain. It's not just a thought or a feeling, it's a brain injury of a certain kind. And EMDR helps to treat that. And if you're doing EMDR, or if you've done EMDR, understand that if you want it to help your facial pain experience of distress, it needs to include memories of your facial pain. And if you've had EMDR, you'll know what I'm talking about. Cognitive behavioral therapy will help with the thinking part, the changes that go on in thinking. So catastrophizing, expecting the worst to occur all the time, blaming yourself, pulling away out of avoidance. It can help all of those things. And then last, but certainly not least, if there's a difficulty with chemical dependency that's developed, don't spend a second, not a second, blaming yourself or feeling bad about yourself. No, no, no. It's something that happens to people. And if it's happened to you, reach out for help. Okay? And so that's what I have. And let's take some questions.
Excellent, Dr. Scott Morrow. Boy, I think you really hit a nerve. You really hit home with a lot of people looking at the chat and a lot of the questions as you were speaking. People are very emotional about the things that you were saying, because I think it really hit home.
Me too. Me too. Because this is hard. This is
Mhm.
really hard, and it can be really destructive and injurious to people.
Mhm.
It's serious stuff. Yeah.
It really is. Well, we do have quite a few questions, so I'm just going to kind of go through them as they came in.
Okay.
There's one that came in about about somebody. I'm going to show them up on the screen. Somebody who was diagnosed with, I don't know if PTSD is a thing, or if it's just supposed to be PTSD, PMDD, and was told it's linked to inflammation in the brain and the brain's rejection to hormones, which is causing anxiety and depression, as well as the TN. So she was wondering about the research on the brain's link to hormones and inflammation, and if you're familiar with that.
Well, it's not really a kind of trauma-related thing, and I'm
Mhm,
not as familiar with it as I would like to be if I were gonna answer a question. But let me
mhm,
just say this, um, there's a lot of good research that teaches us that depression and anxiety are actually inflammatory diseases.
mhm.
So, it doesn't strike me as odd that those things, the emotional things, could be connected to an inflammatory process. But more than that, I really can't say because I'm not, an expert in that area.
That's okay. I wondered about that too, but I wanted to go ahead and get it out there and see if you had thoughts on it.
Sure.
Um, there was a question about caregivers. Actually, there were a couple of them, and Anne from our board was saying that she was realizing the trauma that she experienced watching her mother go
Mhm.
through trigeminal neuralgia. She's
Mm.
somebody who has 3 generations of TN,
Mm.
and then managing more trauma with that than managing her own pain. And so she was asking, did friends and family members experience trauma from watching loved ones, and do they need help too?
Yes! Yes! Exclamation point, exclamation point, exclamation point. We call that secondary trauma, and it's
Mhm,
a real thing. And yes, it does need treatment. And interestingly enough, I didn't go over this in my slide because I really didn't anticipate this, although
mhm,
now that you mention it, I'm familiar, I think, with this person. Um, Under the DSM-5, you can have PTSD from knowing about or witnessing a close family member or friend experience criterion A,
mhm.
stressor exposure. So you can get PTSD outright from witnessing this, not
Wow.
happening to you, but witnessing it. And it
Mhm.
needs treatment just like any other trauma.
Absolutely. Okay. You mentioned doctors and the that you were not here to defend all of them or but we hear a lot that doctors often dismiss this kind of pain and or dismiss this response to the pain, I think. So they assume that your symptoms are just depression or anxiety and that that's not something that they should deal with.
Mm.
Um, and you're not taken seriously. So how to deal with that?
Well, I'm telling you, first of all, where to start? Just the physiological disease or disorder. There are many primary care physicians, and again, I have friends who are primary care physicians. I taught in a primary care residency. I love primary care physicians, but there are a lot of them that don't know. They can't identify what's right in front of them. They don't know. So that happens. Sometimes happens with dentistry,
Mhm,
but let's talk about the emotional piece. It took me years for the pieces to fall in place in my head that there's a connection between trauma and the experience of facial pain. And I treat both. I
mhm.
mean, I treat both. And it took a long time before it went click, 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 click. And I got, oh my God, out of that experience. So I'm inclined to be generous with providers. It requires a little bit of um, it requires a great deal of clinical experience to see the connections here. So I think it would be very common for people to go in to see a physician, psychiatrist, or psychologist and them not see the trauma-related diagnosis kind of crouching underneath the experience. And and especially since the DSM-5 doesn't really come out and make a place for this disorder to cause trauma. I mean, you have to really kind of bend and twist and mold the DSM-5 around this disorder. But it's because it's so rare.
Mm-hmm.
It's a fairly rare thing, and the people who wrote the DSM-5 weren't thinking about trigeminal neuralgia or facial pain when they wrote that part of criterion A. So yeah, people don't get it. And I think the best solution for that is to go to someone who treats trauma.
Mm-hmm.
Because even if they don't know about facial pain, they'll get it. It's like, okay, I'm looking at a zebra now. It's not a horse. That's a zebra. And
Mm-hmm.
they can see that. They can see trauma looking back at them. And where a therapist that doesn't treat trauma, doesn't have specialized training in trauma, they're going to miss that.
Sure.
They're going to call it depression. They're going to call it anxiety. And
Mm-hmm.
there may be comorbid depression and anxiety. Those things may be there too. That happens a lot. But trauma is a different thing, and they may not recognize that. That's why I say go see somebody that does EMDR. They'll be equipped to
Mm-hmm.
understand, teach them a little, and they'll run with that ball.
Okay. And you mentioned EMDR, and you mentioned a couple other different kinds of psychotherapy techniques. This question mentions EAET, Emotional Awareness and Expression Therapy,
Mhm.
which she's found helpful with migraine. And so she's wondering if any of this or biofeedback, CBT, if those are promising in TN as well.
I'm sure. Yeah, they are. But
Mhm.
all of those therapies are more generalized in their approach than, say, for example, EMDR. And I'm really kind of like here to sing the praises of EMDR because I think, especially for facial pain, it would be a good thing.
Mhm.
Those are not particularly trauma-focused therapies,
Gotcha.
but they have a role. So, I mean, you might go in to see an EMDR therapist and you might do half the session doing EMDR, and the other half of the session might be CBT, cognitive behavioral therapy.
Mhm.
I mean, that is probably what happens most of the time. So there's definitely a role for those things. But in addition to that, there needs to be a trauma-focused treatment if the individual is having these more than a few of these trauma-related symptoms. And yes, absolutely, that needs to occur.
Okay. Okay. We've had a couple questions about MVD, people who have had successful MVD, and whether or not you see a lot of this diagnosis following that.
Mhm.
This particular person is experiencing that and really dealing with it
Microvascular
daily.
depression?
Yeah, she just asking if patients are commonly diagnosed even after a successful MVD, if they're still experiencing that trauma.
Sure, for sure.
Okay.
I mean,
Okay.
it's a brain surgery. And,
Sure.
I've had patients treating them on the run up to scheduled MVD or maybe a second or a third MVD. And those are interesting patients,
Hmm.
you know, i- and they're scared.
Of
It's a
course.
big deal, it's a
Yeah.
big scary thing. So even when it goes well, that anxiety going up to the procedure and recognizing that this is a brain surgery. I mean, this is a brain surgery and it's scary. So sure, that can be traumatizing. Absolutely. Even when it goes well. Yes.
Of course. Of course. Okay. I thought this was a very interesting question. What three takeaways or implementations would you want someone to think about to improve their quality of life when managing with constant neuropathic pain?
Wow.
Lots to
Wow.
think about.
Well, I would say this. It's a big It's a big deal. I
Mhm.
almost let an obscenity slide there. It's a big thing, but it's not life-ending. And as far as the emotional pieces go, and again, they are really tangled up like a root system, like two trees growing close to each other, and their root system gets all tangled up. So on the one tree, we have this physical experience. On the other tree, we have this emotional experience. But in their root systems, you can't tell one from the other. I mean, that's what happens with any chronic pain, but especially any chronic neuropathic pain. And we know that neuropathic pain, chronic regional pain syndrome or neuropathic facial pain or any of those neuropathies, the pain is worse when people are agitated and anxious.
Mhm.
So even though we may not be able to eliminate that physical component, if we can treat and manage the emotional component, so take care of that tree, it can create an abundant improvement in the experience of life. And so I would say that a big takeaway for the person experiencing chronic neuropathic pain is treating the emotional piece, even if you think you're doing great, you know, even if it's hard to admit you're not doing great, treating that piece can make a big difference. And so that's just one takeaway, but that is the takeaway.
Okay.
Yes, reach out for help.
Mhm. Excellent. Um, this is probably quite a unique situation, but actually, with people with facial pain, I think certainly during flares, there's many that tell us they cannot speak. And so I don't know if this is a chronic condition with this person, but um, she asked, do you have advice for how to get therapy when you can't speak? She has glossopharyngeal neuralgia and
Ah,
just can't talk without pain. So there's
ah,
anxiety and fear about the pain before it even comes.
right. Well, okay. Anxiety and fear about the pain before it even comes is a trauma response.
Mhm.
I mean, bingo. And so the question is, how can I do? I think this is a question. How
Mhm.
can I do psychotherapy when I can't talk?
Mhm.
And this is a talk therapy.
Mhm.
Well, what I would say is EMDR, and here I am again, isn't necessarily a talk therapy. So, or another approach called systematic desensitization. So, not necessarily a talky part on you're getting better. It's not really dependent upon your capacity to talk. You have to talk a little bit, but you can write. And so both of these therapies, these desensitizing therapies, involve creating a kind of hierarchy of imagined um, experiences of trauma. So, and then we're going to use a certain methodology to decrease the anxiety and distress and fear that one experiences when they think about the trauma. Okay. So you can do EMDR. And I'm doing this because it involves a kind of bilateral stimulation without talking.
Mhm.
Y- And, and, and so I would say, while that would create extra challenges, it's not a deal breaker. I mean, I think I could treat a patient who couldn't talk very much. Um, we'd have to do some writing,
Sure.
but I think it could be done.
Interesting. Okay. Thank you. You may have addressed these in your talk, but I just want to make sure that we get it covered. What are your thoughts on central sensitization, neuroplastic pain, and pain reprocessing theory?
Mm, hmm, interesting. So, central, centrally mediated pain is pain that originates in the brain. And you may say, well, of course, it's trigeminal neuralgia, you silly person. Of course, it originates in the brain. But okay, I'm talking about a different part of the brain. And what happens with the chronic experience of pain, the brain weirdly learns to experience pain and it gets better and better at it. And that is centrally mediated pain. And, it can also occur from the use of opioids. Opioids can cause that centrally mediated pain, central sensitization. And I do think that there is a role for psychology in the treatment of central sensitization, especially in terms of ratcheting down the hyperarousal that can go with pain, because that will trigger pain in itself. And so relaxation therapies do have a role. And definitely if there's opioid escalation, which happens, right? I
Mm,
mean, it's just admit it, it happens. And that will cause central sensitization. It will change those uh, neuro connections, those synaptic connections, and it will make for a centrally mediated experience of pain. That should be treated.
Excellent. Okay. You talked a lot about guilt and about the feelings associated with um, not connecting with your family, or not feeling how you think you should feel with your family.
Uh,
And this person talks about feeling like the family's already getting tired, already a burden, that they're already a burden. So how do they deal with then also saying, okay, now on top of everything else, I have PTSD?
oh my God. So let me make sure I'm understanding the question. The question is, this individual
Mhm.
feels that they were already experienced as a burden,
Mhm.
and on top of that, they develop facial pain.
I think maybe it's the other way around, that the
Okay.
family feels like they're already tired of dealing with the facial pain, and so now after hearing you in this session today and learning that maybe some of what she's feeling is a trauma response,
Mhm,
and that she may have this chronic PTSD as well,
mhm.
that now that's just another thing to add on to everything she's already been dealing with her and that her family's already been dealing with.
Well, okay, so I would say this to that. If there is indeed a trauma-related diagnosis, learning about it today didn't create it.
Mhm.
It's been there, and just having a name for it is really it's a good to understand, but only because it can motivate you to get a certain kind of treatment. So I, I think that there is it's important to say this. People can be so burdened by things that are bad or hard that family members push away because it's hard to see, and it makes them feel helpless. And people hate feeling helpless. People hate feeling helpless. And
Mhm.
so when they're confronted with a family member suffering, yeah, people do pull away. Family members pull away. And that's why I think it's very, very, very important to go to a therapist, because the therapist is not going to pull away. Not a good therapist.
Mhm.
A therapist will know how to protect the relationship so that it doesn't get damaged. A therapist will know how to take care of themselves. And it has a certain structure. I mean, you're meeting at a certain time for a certain length of time. And so that structure preserves the relationship. And it is important to go take some of this heart burden, some of this soul burden there, and share it there so that it's not spilling over as much onto the family, because it can be damaging.
Yep. We are coming to the end of our time today, so I have one last question I'm going to ask, and this is really a clarification question. And there's a couple other questions within the Q&A that have alluded to this, but the question is that TN is a physical pain. It's
Mhm,
not an emotional pain. It's a physical pain. There's a physical cause.
mhm.
Why does it appear? And I don't know that this is the case, but that you're saying that the pain is from emotions. So can you just clarify?
Oh, I'm not saying that. I'm not
Yeah.
saying it's from emotions.
Yeah.
Mm-mm. No, it's physical. But
Mhm.
just in the same sense that I might be treating, like I had a patient who had PTSD because he was working at a steel plant,
Mhm.
and floor gave out underneath him and his leg went through into the molten steel. I worked for a while on a burn unit. That's how I met this guy.
Mhm.
And talk about real pain. I mean, that's real pain. But they also really had PTSD. So I think of TN in the same way. I mean, it's real physical pain.
Mhm. Just emotional pain associated with it.
Yeah, how can you not
How to treat
experience
that,
emotional
right?
pain? When you're going through that, how can you not experience emotional
Right.
pain? Or you're
Right.
not a rock,
Right.
right?
Right. Exactly. Exactly. Well, thank you very much for taking the time to answer all these questions, for sharing your thoughts. I think this was, again, just really hit home with a lot of people. There were a lot of emotional um, entries into the chat. So I
Yeah.
just can't tell you how much I appreciate it.
Well, in parting, let me say this, you know,
Course.
I am available to the extent that I can be
Mhm.
for questions that come up after this, so they could go through you. And if you kind of think that it's something I might be able to help with, just fire me an email.
Absolutely. We have we're getting this whole session transcribed and we'll have that, but then we also have access to the Q&A and to the chats after the fact. So I will go through and find ones that I think maybe, you know, that you'd be able to answer that weren't addressed today. So
Okay.
I appreciate that. That's a very nice offer.